Hello and welcome to DIY Therapy. As always, we'll start with our disclaimer. This podcast is for educational purposes only. It is not designed to diagnose or treat. When beginning any exercise program, it should be reviewed and discussed with your medical professional prior to beginning. Information on this podcast is not designed to replace medical treatment. My name is Will. With me, as always, is Andy. Powered through that, even though you were interrupting me with your grunts and whatever it is, throat clearing.
I've got another cold.
Is it another cold, or is it just still the same cold?
No, actually, I feel fantastic today. So if I do not,
if you ramble on,
I stumble all over my words and don't make any sense, like the neck podcast, then that's just because I'm an idiot and I don't have anything to blame that on.
Or you're just feeling so good that you're just. I have so many words I have to get out.
I'm flying high, man. I'm flying high. I'm ready to go. I'm pumped. We haven't done We've been like a couple weeks off here, haven't we?
Yeah, with with Easter and we had technically we didn't have that other week off, but you were just so out of it that you don't really remember being there anyway.
I should not say this on the air, but I'm going to anyways. I went to work the following Monday after we saw each other over the weekend, and I barely remember like the first 3 or 4 patients. And I was telling Nancy, our receptionist there, and I'm like, who are these people? When I was seeing them later in the week, I'm like, I don't remember seeing any of these people. And she's like, yeah, you're kind of out of it. So
nice.
Yeah. So that's I don't want to not promote our neck podcast, but that was kind of the same state I was in then. So
it's a bit of a dicey one.
Go check that out if you want to see somebody delirious.
Or hear somebody delirious.
Yeah, there you go. So topic today.
We're just going to talk about the beginning stages of an ACL after an ACL surgery. Yeah.
So the ACL in general, what is its function?
The ACL stands for anterior cruciate ligament.
Attaboy!
Yay.
I knew you did some background studying on this. I knew you did. So the ligament itself, people hear this ligament all the time because it's probably one of the most, 15 years ago, it was a devastating injury that if you had as an athlete, it could severely affect your athletic career, and there was a real big question on whether or not you could ever recover. The science behind it and the recovery process of it all now has become so specific and so successful that it's no longer this injury that all of a sudden could compromise the rest of your athletic career. So it's really cool the way that science has progressed over the last 15-20 years.
That's the funny part about that is it's progressed because of the athletics, because the amount of money that the athletics is bringing in.
Absolutely,
they're able to focus in on that.
Yeah. So the ACL in general is a ligament that sits inside the knee joint itself. So you've got your femur, which is kind of your top bone, and then you've got your tibia, which is the big bone.
Shin.
Your shin bone. And so it attaches the femur and the tibia together. When we cut, it keeps the tibia, that lower bone, shin bone, from actually sliding forward, and without it, what you'll have is a lot of what we would consider like anterior or front movement of that tibia, which puts way too much strain on the knee and creates a lot of pain, instability, arthritic changes, and it doesn't allow also those muscles to, like the quadriceps and the hamstrings, to actually function correctly to where you can move, cut, twist, and do all these types of athletic movements. And eventually what it'll do is that the ligament isn't intact. It'll cause more damage and structural problems for the knee, especially if you continue to participate in athletic types of events or activities.
Yeah, just for a stability aspect. I mean, you can walk around without it and it's fine, but if you're running and you try to do a fast stop or something to that effect, or you're tackled or anything like that, and your foot is especially planted, you're boned. I believe it's a technical term.
So it's definitely a surgery that if you're in athletics, that you want to continue to participate in athletics, you should have. I think probably we could do a whole other podcast on the pros and cons of probably doing a surgery versus non-surgical if you're not in the athletic kind of space or realm. Like, so say you're someone like me who's even, 36-year-old guy that likes to just run, but at this point in time doesn't do anything, really athletic, but just is running straight line. Is there a benefit from those ACL repairs, or should it be something that you just rehab and get strong, et cetera? There's a lot of research that indicates that maybe you shouldn't. So we can maybe save that for another podcast. But I think for this podcast particularly, we'll look more at kind of that phase that, once you have the injury, okay, and we could maybe do a series where we could do like a preventative, like an ACL training preventative one too. So we could do ACL preventative, we could do ACL, kind of that shouldn't you have the surgery. This one particularly, we're going to look at, okay, let's say you have an injury, okay, what is it that is occurring what should you be doing before you have the injury, and then what maybe you should be doing those maybe 1 to 2 weeks before you get into therapy.
Yeah, with the focus on, before you, to kind of prime you for therapy, essentially, to get the better outcomes. Yeah.
So when you have an injury, it's really interesting because a lot of times when people think, okay, I've got an injury, I've got to get right into surgery, let's get this fixed and started as quickly as possible. And actually for ACL injuries, that's not the case. It's not one of these things where you want to get right underneath the knife and get that surgery done the next week. There's actually very specific pre-operative goals that you want to have prior to going and having surgery. So really what they found is with research is that if you can control swelling and have almost no swelling in the knee prior to surgery, if you can increase your quadriceps strength prior to surgery, and if you can restore kind of normal range of motion, bending the knee, up to 80, 90% of your range of motion and getting the knee straight, all prior to surgery, then the outcomes after surgery are significantly better. Yeah. So sometimes people will actually have surgery anywhere from a week, anywhere from 2 months, 3 months down the road. Kind of standard swelling, pain control type of things. Obviously we want to do a lot of icing after surgery. Elevation is going to be something that you want to try to do on a regular basis. And then, you're going to want to try to, as soon as your pain is less, you're going to want to try to do some gentle range of motion, stretching to kind of try to, maybe like heel slides or straightening out the leg, just kind of letting it hang over, put a towel underneath your ankle and let it kind of hang and kind of straighten out the leg.
Let gravity and then, do the
of course,
work.
What's that?
Let gravity do the work.
Yep.
To straighten it out.
And then really more or less some quad sets, which is tightening the top of the thigh. And then maybe some heel digs where you're trying to get the hamstrings kicking in a little bit. And again, wanting to normalize your walking pattern so that you're not limping. So reaching those goals, those are really the big things that you want to get to prior to actually having that surgery. So food for thought with that. Don't think that you need to get to the surgery as quick as possible, and that's going to give you the best time to recover. You'll actually have better recovery and better return to function following.
Yeah.
That's it, huh?
It's
okay. You don't have to add it.
No, because this early in the stage of the healing process is basically just range of motion and beginning parts, control your swelling and beginning parts of strength.
Mm-hmm. Yeah. And so then obviously once you reach those goals, the surgeon will go ahead and have do the surgery with you. There's different types of surgeries. There's where they actually will use a cadaver ACL. There's where they'll take your leg turns into a zombie leg. So there's a cadaver. surgery. There's where they'll actually take a graft from your hamstring, one of your hamstring muscles, or tendons, I'm sorry.
Nice.
And then there's also the patellar graft, where they'll actually cut part of the patellar tendon and suture that back together and use that as a graft. So what they're doing is they're removing the inside, the actual tendon itself, and taking it completely out inside the knee and then replacing it with these different types of grafts. Again, those three different options. And there's pluses and minuses really to all three. Those are conversations, again, you should probably have with your surgeon, and it depends on what you're wanting to do, and what activity level and how quickly you're wanting to recover, et cetera. But surgeons are always going to have their opinions, and there's different research that kind of supports all three. Have candid conversations with them. It's important to have that discussion with them.
Yeah.
But I don't know if have you had any particular success or not success with one versus the other? I can't say that I've really had.
I've not noticed much of a difference. It's the biggest difference I've noticed with anyone is just the participation of the patient.
Yeah,
right? It's just
and the one thing I'll say is like when they do like a patellar graft, you tend to have a little bit weaker quadricep to begin with, but I think that graft tends to be a little bit stronger. With the when they're taking a cadaver, there's always a chance of rejection for that one.
Right.
So they're not cutting out the rest of your body, but they're not damaging another portion of your body by bringing another graft, but they're essentially, there's a chance that graft could actually be rejected because it's not your own tissue. Although they do certainly test some things like that for that to make sure that there's a nice fit there. But there's pluses and minuses to all of them.
Yeah, it's hard to know what it depends on what like you said your goals are going to be after the surgery.
Mm-hmm. Exactly. So let's say then you have surgery, right? So then the next step is really like right after surgery, they're going to place you in a knee stabilizer, immobilizer, and essentially what they'll probably ask you to do is wear that and really walk as much as you can based upon pain. But a lot of that is going to be really the same thing right after you have your injury. Is you're going to be looking at trying to control the knee swelling and the pain that you're going to do with elevation. You're going to make sure that there isn't any signs of infection. Signs of infection include, increase temperature, fever, obviously any type of discharge that is not clear and or maybe blood coming from the incision sites. If you're looking at green, yellow discharge, that's obviously not good. You do want to monitor like any kind of redness around the incisions and the portholes. However, that's not something that you need to be terribly concerned if there is a little bit of redness, but if it starts to grow, a lot of times I'll tell people to, kind of take pictures of it and see to make sure that over the course of a week, 2 weeks, that it's not actually growing. Significant heat coming from the knee could be a sign of infection, but
that's a tricky one because warm is normal. It's got to be like hot, almost like you went for a run and it's just like hot. You're going to have some edema or swelling that actually occurs just from the surgery, anyways, and so you're going to have some heat that's just kind of coming off of the body at that point. But it's something where it's significantly hot. So you want to take these things all with a grain of salt and kind of look to see if some of them are if you're having more than one of these types of symptoms too, that obviously makes you be more alert of these things. And so you want to make sure about the signs of infections, and then typically for like the first week or so, people are using crutches, and you're usually doing about 50% weight bearing, meaning that you're just kind of putting weight through it, but not putting all of your weight through that leg. And again, you'll be using the knee immobilizer, which most likely won't be allowing you to bend the knee. It'll lock that knee out. But again, early goals of all of this would be to increase that range of motion,
increase extension. Extension is a big one. And then quadricep strengthening. Those are your other big things that you want to try to hit home early on, because the earlier you get to those things, the more quickly that you're going to be able to recover. So, I don't know, a couple things that you can do. What are a couple things you can do for early range of motion, Will? Kind of talked about them earlier. But.
Yeah, just gentle, we call them heel slides, but imagine laying in bed or a flat surface and keeping your foot in contact with whatever surface that is and just sliding that up, basically bending your knee, we call it a heel slide because you're sliding your heel along the surface. And you're just bending it up or bending it and then straightening it. That's a kind of for the bend. And for the straight, which you alluded to, is basically you can do it sitting or you can do it laying down, but basically you want to have something underneath your heel on your foot so your knee isn't necessarily touching, isn't supported, and just so gravity can do the work of straightening your knee for you. You will find that going straight is always the worst. It's the most uncomfortable for everyone. No one likes it. Bending, because it seems more of a normal motion, whereas the straightening, it's almost like everything wants to fight it. But that's the important one, in my opinion, getting it straight.
Yeah, and I agree with you on that. Typically you'll be on pain meds early on too, which will help with you managing the pain. Again, ice elevation. You'll probably be put on an anti-inflammatory early on too to help kind of control that inflammation. And they'll probably give you like a wrap of some kind or a sleeve of some kind to try to control some of that swelling, because that swelling is really, again, important to kind of get over so that you can start to move that knee a little bit more. And another just important note that I'll just add on about those heel slides that Will was talking about, you're not forcing the range of motion. None of this at this point in time is where you're getting real aggressive. This is all gentle range of motion.
Yeah, just moving to whatever you can get without a whole lot of pain.
Yeah, and taking your time, not trying to do it all in one big, not trying to stretch the knee in 30 seconds. You're taking maybe 5 minutes and just kind of slide that knee back and forth and kind of slowly loosen it up. Typically the first week, you're trying to get that knee bent to 90 degrees. In week 2, you're usually trying to get to about 110, 120, and trying to get to end range of motion or full, pretty much 90% of your range of motion by the end of week 2. Week 2, also, you're looking at trying to increase the weight bearing, usually more like a 50 to 75% weight bearing, and maybe even transitioning to, instead of using one crutch or 2 crutches like you were in week 1, using 1 crutch in week 2, all the way to where you're hopefully full weight bearing or fairly close to it by the end of the 2nd week and into that 3rd week. But by that point in time, you should be scheduled up with your therapy. Sometimes there's delays in that, not usually, but at that, usually you'll get into therapy within the first 2 weeks. That kind of takes you through, I guess, what we were going to talk about. We actually went through that pretty quick, didn't we?
I mean, there's not a lot to it, but it's good so people know.
Yeah, I think the big thing is that a lot of people don't realize is that you want to actually delay the surgery,
right?
And that's when I talk to patients, and they're almost kind of, maybe someone hasn't even discussed it with them, and they're almost kind of perturbed a little bit, like, yeah, and it's been 6 weeks. I wanted to get the surgery started so I can get done with it, and they don't understand that if you get going with this too quickly and you've already got an injury, then you go in and you have surgery right after that, which just is essentially going to compound the problem with the inflammation and the irritation in that area, that just really slows down the recovery process. So I think that's probably one of the biggest pieces that I think maybe the general population don't understand, that there should be a waiting period there. And I think that also comes from you hear like athletes that have surgery for their ACLs, and a lot of times you see here, they had their ACL and they had surgery a week later. Well, they're also having world-class rehab afterwards, which does make a difference.
Yeah, they have people dedicated to
their job is
their job is literally recovering. And they have They're probably doing things that aren't even really necessarily helping. They're just throwing everything at the wall just because it might help.
E-stem, ice, all day long they're just getting treatment following that. So, for the general population here, it's the best route that we know of at this point in time based upon research. So,
right.
Yeah. Cool.
So that's the beginnings of the ACL.
Yeah. Yep. Anything else going on with you?
I mean, besides Game of Thrones.
I knew this was coming.
So, as of this point, we are second episode into the last season.
Wait, hold on a second. So, like, a lot of these, we've noticed that with a lot of our podcasts, people will listen to, like, 4, 5, 6, 7 weeks later, even, like, several months later.
Right. So, because these are basically evergreen because the topic doesn't change because it's not pop culture. So we are the second episode into the second season, last season, right?
Season 8,
whatever that is. It's math.
Sure.
I was assured there'd be no math.
So spoiler alert. As we rant about this for a little bit, initial thoughts. What do you think?
I really enjoyed the bits and pieces of everybody's, like, especially like all this kind of, like, I don't really want to call them side characters, but all the side characters getting like a little moment to kind of like all kind of get together and just have little conversations and, like, character little bits like that. John and his inability to come up.
I'm shaking my head right now.
Yeah. Everyone has a very weird perception of importance of things. I think is a good way to put that. Whereas John's isn't like, his first thought isn't like, oh my God, I'm sleeping with my aunt. And that's definitely not Daenerys's first thought either. Her first thought is like, oh no, you got a claim to the throne. That girl's got a one-track mind. Yeah.
Like, my first thought would be, oh my God, what did I do?
Yeah.
Oh my God, I'm gross. It was, I thoroughly enjoyed the episode, but the thing I find interesting about it is it's like, one, I think sometimes it's a little bit bad storytelling. Like, there's a conflict between Sansa and
I think it was better.
Daenerys.
I think it was better explained this episode than it was.
But they made it up. They made the conflict, and then they cut away through a knock at the door, and they never actually. And they just kind of always tend to do that. That's kind of a pet peeve of mine. It's fine. That's not that big of a deal. And they did it actually with Daenerys and Jon when they were explaining his heritage at the end.
Yeah, too. We're all of a sudden like, oh, the dead are here. Yeah.
Yeah. But I did really enjoy the moments with the characters, specifically with Brienne.
That whole little scene there was good. I really like that bit.
It's all setting everybody up to, hey, hey, we're investing in these characters, and all of you have the potential to die next episode.
Yep.
And most likely half of you will. And so, bye-bye.
Yep.
Yeah, but overall, I enjoyed it. You know how I feel about Game of Thrones.
Yeah.
I very rarely am I disappointed. So, yeah. I'm excited about the next episode.
We call him this, but Bran, we call him Google. And
yeah, yeah.
I was listening to some of their podcasts, and they called him Google too, and I was like, that's great.
Yeah, they stole that from us. No, they didn't.
No, we never told them. We never said that out loud.
Yeah. But yeah, excited about that, and then I'm going to go see Infinity War tonight, opening night.
I hate you.
And you're going later this weekend, and so we'll probably chat about that next podcast, I'm sure.
Yes.
So, all right, let's wrap this guy up.
All right. This podcast was for educational purposes only. It is not designed to diagnose or treat. When beginning any exercise program, it should be reviewed and discussed with your medical professional prior to beginning. Information on this podcast is not designed to replace medical treatment. Remember, treat yourself.